We can start, madam.
Okay. Good evening to all of you. Today, each time I will take one portion of pharmacology based on a clinical case discussion. And in pharmacology, I've got varieties of things like medication error, prescribing review, how to prescribe, when we encounter dose errors, and with that, what toxicities can we encounter. And then before that, we will see what are the actions and uses so that can we use in that scenario or not. Are we doing some wrong things? All these we are doing in 1 hour, but in front of the patient, you have to finish it within 1 minute. So, this broad view gives you an idea of how to really go along with your practice as well as with multiple diseases, multiple comorbid diseases, one. And second, today we have a lot of polypharmacy existing. So, we want to know various drug interactions, pharmacodynamic features, kinetic features, the factors affecting the modifying the drug effects, and also how the body reacts. Can we really give it or not? Looking into the major organs like cardiac, renal, lungs, brain. Brain is not to that extent, but it is to a little extent. But in order of choice, it is mainly the interplay between the cardiac and the renals. And secondly comes these pulmonary, and later on the last is the liver. So there is an interplay between these when a foreign drug enters into the body. So we have to review in all possible cases, looking into almost about 30 points, and that 30 points should come to 1 point in when you sit in front of a patient. So let us look upon today some things about the prescribing review. Then we will look upon to the drug interactions, and we will look upon to the mm, drug prescribing. So three different scenarios I will take for each one of them, and in between whatever is being prescribed, that major topic I'll try to discuss few things so that you can remember and see that which is better, when, where, what, why, how. So these are the things in a nutshell what I want to speak. And every time I'm doing this, but I'm reinforcing this so that you will better understand the interplay of all these drugs, because you have to remember, as long as you put that prefix before your name, that is the DR. So with this we will start today. This is the prescribed. I think this should go on up. Okay, this is the prescription medication review. Okay, this is the prescription medication review. So what is the question for this? Of the commonly prescribed drugs, identify the two that have dosage errors. I hope you know the meaning of the dose and the dosage forms, okay, and frequency of administration and duration of administration. And also, parallelly, you should know the onset of action, the peak action, and the end action. And lastly, the plasma half-life. All these put together, you will know what to prescribe at what time, how much, what, where, etc. So now we will look into these many drugs where they have given it for a patient who is on depression and also who has some DVT. And together with that, they have normal non-specific body pains, and some of them nowadays it's common, no? When a person comes, they say body pain, so we write one drug. They'll say some sort of gastric. I don't know what they really mean by gastric. It is not gastritis, it is gastric. So we write some omeprazole or something like that. Then we write for some DVT or something like that. For all these things, we see to it that apart from DVT and bipolar disorders or depression, then insomnia. Amongst this, we have three more commonest one, that is gastric, non-specific pain in the body, and very tired. So we always try to prescribe some vitamins and minerals. Then we try to prescribe some NSAIDs for their body ache, and then because of gastric, we normally prescribe these anti-ulcer drugs, depending on the doctor, not on the patient. So these are the whole scenario what you can depict by these drugs. So now let us see. Now I have just depicted. I'll give you a glimpse And later on, few important points about this, so that we will take in further coming classes, each one of them in a very detailed manner. But overall, you should know, but I will try to complete all of them, maybe in one sentences now, in some of the cases broadly also, but the whole thing is communicated to you in a very better way. There is no problem. Okay, so as all of you know, aspirin, the main indication for aspirin today is low dose aspirin as an antiplatelet agent in prophylaxis as well as treatment of all cardiovascular conditions, including diabetes, hypertension, and obesity. So these are the ones, and including pregnancy. Okay, so it is basically as NSAID. Previously, when about 3 decades ago, it was only anti-inflammatory, analgesic, and antipyretic. Now, the main action is, it is low dose aspirin, which is 75 to 150, prescribed in all cardiovascular conditions and also in case of diabetes and hypertension as prophylaxis. The And here the dose is mainly 75 to 150 for prophylactic. This one is for 75, and for treatment it is 75. Of course, it is always administered orally, preferably at any time of the day, but preferably at night, especially after food, because we have to see that there is no NSAIDs induced gastric ulcer. NSAIDs induced gastric ulcer. Okay, so these are the ones what you have to know completely. Next, Dalteparin is nothing but an anticoagulant, injectable anticoagulant, congener of enoxaparin, which we are using very daily, and it is a low molecular weight heparin, and it is prescribed as 5,000 units and given per orally. Just now I told you the route of administration. If you are very catchy, you can do it, and frequency, of course, is OD. Next, ibuprofen, it's also an NSAID, but mainly an analgesic rather than anti-inflammatory and antipyretic. But the most commonest non-rational combination is ibuprofen with paracetamol, most often imol or combiflam, where this has got only an additive effect. We are posing more of adverse effects than beneficial effects. Ibuprofen is also analgesic or very moderately antipyretic and anti-inflammatory. And paracetamol is basically antipyretic and moderately analgesic. Both of them put together, you don't have any synergistic actions. You have only additive actions. So, and in case of additive actions, I don't think you should really put multiple combinations so that you are destructing the harmony of the physiological milieu. Instead of that, you can prescribe it as all alone. So this is usually prescribed as 400 mg per orally, and it 3 times daily, as the plasma half is about 4 to 6 hours. Omeprazole, I think it's a over-the-counter drug. Every fool knows about this. And this is one of the drug which is an enzyme inhibitor. That you should remember. It is an enzyme inhibitor and it has got a lot of adverse effects. And also, it is a non-competitive inhibitor at H plus K plus ATPase pump in the parietal cells. The dose is 40 milligrams per orally OD, but usually it should be 20 milligrams BD. Okay. And most of the times we give half an hour before food, but in reality, according to the physiology, you should give omeprazole or any PPI at the maximum acid secretion in the body for the day, that is morning 7 o'clock. That is the ideal time where we have to administer any PPI. But we are using left and right as and when we can, which is really wrong. But who will build the cat? That's the problem. Okay, that can be given on both OD and esomeprazole can be given IV also. Next, coming to paracetamol, which is a COX-3 inhibitor acting in the hypothalamus, mainly used as antipyretic, and 2 gram is the dose. Oh God, I don't think anybody can survive with this, and the liver, which should really go at 80, will go at 20 itself. So this is the problem, and it is given as QDS 2 gram. Fantastic. So this is one problem. Next, sertraline, which is an SSRI, which is given for resistant depression. The drug of choice for SSRI is normally escitalopram. Then we look upon to the other problems, then go on to fluoxetine, flevoxamine, sertraline, paroxetine. Later comes the citalopram and citalopram, but by prescribing it is the ulta order. Most often we prescribe citalopram, both in unipolar depression as well as bipolar disorders, along with lithium or other bipolar drugs. The dose is 50 milligrams, but actually it should be started at as low as possible. Of course, per orally and orally. Zopiclone, all of you know that it is a non-benzodiazepine favorite sedative hypnotics, where we can give it at night at about 8 o'clock, and by morning 6 it is they're as fresh as the word Z. Okay, so it's very nice. The other drugs are they are also called as Z compounds. Apart from non-benzodiazepine sedative hypnotics, they are zopilone, and zolpidem, and S-zopiclone. And the minimal dose is either 2.5 or 3.75 milligram per orally OD. But you have to specify here when it should be given: morning, afternoon, night, or it's only in the afternoon or only in the night, which is not there. Still, amongst the lot, you find that Dalteparin and Paracetamol are the two things where they've asked for dosage errors, and definitely there is a dosage error both for Dalteparin as well as Paracetamol, both by the prescribed dose, route of administration, as well as frequency. So let us see now a little glimpse about the others, and later on coming to the dose. Now, here, most of the times we want to know the important indication. More than that, we want to know the toxicities. We should be alert. It is like a theory viva. Toxicity is like theory viva. We should act for the toxicity, but for indications, especially chronic indication, we can really think, and then answer. So my common statement is, for all acute indications and toxicities, you act, no question of thinking. Whereas for all chronic indications, you can think, and then write it. No harm is done to a very great extent. There is always a exception to every rule, but most of the times you can buy time for chronic indications, but never and never for acute indications as well as acute toxicities. So looking into the anticoagulants, most often they're, I think all and drugs used in thrombosis, that is anticoagulants, either injectable or oral anticoagulants. And in that, you have got varieties where it inhibits antithrombin 3, where it inhibits factor 2A, where it inhibits factor 10, or all the anticoagulants, they all have the common uses, and most of them have the common adverse effects. But later on, when they go on blocking the specific ones, the toxicities decrease. But as a general rule, all anticoagulants have the toxicity of bleeding. If it is oral anticoagulants like warfarin, the antagonist is vitamin K for warfarin. And if it is overdose, acute toxicity, you have to give fresh frozen plasma. Why fresh frozen plasma? Because vitamin K takes 24 hours to really see about 2, 7, 9, 10 factors, whereas fresh frozen plasma, you have got a ready-made thing like Zomato or anything like that. And so you say that for acute overdose, patient is bleeding heavily, the BP is going down, hypertension, etc. So in such cases, you give fresh frozen plasma transfusion. So this is about little bit a glimpse of in anticoagulants, where commonly we use low molecular weight heparin, subcutaneous, oral anticoagulants. Previously, we were using warfarin. Because of drug interactions, now we are using oral thrombin inhibitors, that is rivaroxaban, dabigatran, most often. These two are the ones, rivaroxaban and dabigatran. Apixaban, apixaban is a platelet inhibitor, whereas apixaban is an oral thrombin inhibitor. Along with that injectable, we have fondaparinux. These have got very specific things, so we need not bother much about INR ratio and other things. So these are the ones which are mainly used, and these are the ones where we see the indication and toxicities. Amongst opioids, which are, see, in pain management, four main things are used. We'll take up that in a separate entity. The four main areas where pain management are included are NSAIDs, non-steroidal anti-inflammatory drug. The prototype one, when we are teaching in the college, it is aspirin. When we are practicing, it is diclofenac. Okay, next comes opioids. In opioids, most often we use in the chronic pains like cancer pain. Most often nowadays we are using it as patch, buprenorphine and fentanyl. Lastly, when there is no affordability, we use morphine orally, but very minimal absorption takes place. But we have to see the quality of life and see that they're okay, like to the household. So for that reason, we use oral morphine. And beta blockers, sorry, pain management, one is NSAIDs, second is opioids, third is local anesthetics, lignocaine, which comes in all dosage forms, right from topical to IV, and lastly, it is general anesthetics, where the patient cannot really bear the pain. In such cases, we can go till the level of general anesthetic also. And most of them have respiratory depression, and you have to combat this. The toxicity and the death might be due to respiratory depression, especially with opioids, and the antagonist being naloxone in acute, whereas chronic opioid dependence we use naltrexone. Now coming to beta blockers, as of you have non-selective beta blockers like propranolol, selective beta blockers like metoprolol and atenolol, which is no more used pre-diabetic, and you have esmolol, all those things, and we have vasodilatory beta blockers, which are the drugs of choice today: carvedilol, labetalol, and cardiolol, and also bisoprolol, as well as nebivolol. So these are the drugs which are mainly used. Hypertension is wrong. The first one, if you say as hypertension in UG, we give half mark or no marks, whereas in PG and as consultants or anywhere else in practice, if you write beta blockers, the older ones for hypertension, your acumen is zero. So if at all you want to use hypertension, it should be only bisoprolol or it should be nebivolol. And in patients who are below 40, where sympathomimetic activity is in a high condition. So the first choice for beta blockers is always arrhythmias, CCF, post-MI, cardiomyopathy, lastly hypertension. Okay, so these are the ones which are used, and the most common effect toxicity what we see with all beta blockers is bradycardia and hypertension. More than hypertension, it is bradycardia, or remember ABCD: asthma, block or bradycardia, then coronary vasospasm, diabetes. So these are the ones which we commonly see, and especially for bradycardia, we have glucagon as the drug of choice. What is glucagon? Glucagon is an hormone which is synthetic physiologically. But here it acts through the beta receptors, and hence it will combat the toxicities of bradycardia. And if it is mainly sympathetic only due to some other cause also, we can definitely give even isoprenaline. We can give it isoprenaline also. Next, coming to benzodiazepines, we have varieties of benzodiazepines as anti-anxiety, sedative hypnotic, anti-epileptic, used during anesthesia or even anxiolytic. So we have got all these benzodiazepines by names like diazepam, lorazepam, estazolam, midazolam, chlordiazepoxide, etc., etc. And the very, very important indications are most often in insomnia and anxiety, and especially in seizures as status epilepticus, and later on in febrile convulsions, mainly, but not used in chronic epilepsy. In chronic epilepsy, it is mainly used as adjuvants. And toxicity mainly is sedation and dependence. And in any acute overdose, we use flumazenil. There are non-benzodiazepines also, as I told you earlier: zopiclone, zolpidem, zopilone, and zopilone, where we have these drugs where the dependence is very, very less, though other actions are similar to benzodiazepines itself. So in acute overdose, you use flumazenil as the antagonist. The NSAIDs is non-selective COX inhibitors like aspirin, diclofenac. Then selective COX-2 inhibitors like rofecoxib, celecoxib, paracoxib, and valdecoxib, whereas rofecoxib is out. Okay, within 1 year, company made a lot of money, but it just caused harm to the patients. That's why it was withdrawn from the market within a year, where patient died of cardiac problems because it didn't have that antiplatelet activity with as like with non-selective non-selective NSAIDs. So it was withdrawn. Nowadays we use either valdecoxib or paracoxib, and more so celecoxib. Still, we have GI with selective COX-2 inhibitor. GI bleeding is not there, but renal injury is definitely there. There is no direct antagonist. Most of the NSAIDs are treated by forced alkaline diuresis. Forced alkaline diuresis. The last one, I hope you can see the antidepressants, where there are tricyclic antidepressants like imipramine and nortriptyline and amitriptyline, whereas the newer ones are SSRIs like flevoxamine, fluoxetine, sertraline, paroxetine, and citalopram and escitalopram. These are all SSRIs. They have got umpty number of advantages over the previous ones, but we are afraid of the serotonin syndrome. So there is no specific antidote for this. So you have to depend on all those anticholinergic effects, alpha blocking effects, etc., etc., and treat it accordingly. So now what was the question? The dose errors. What was the dose errors? It was in the two things. One was Dalteparin. You understood? Dalteparin was one and paracetamol was one. For all the others, it was quite okay. Okay. So now coming to the conclusion, enoxaparin is a low molecular weight heparin and should be administered only subcutaneously, not orally. The same is a congener, Dalteparin. So it was administered orally. That was wrong. Next, we will see what was the dose. Dose is 100 units per kg, where they are given 5,000 units. It should be BD for 5 days, but they have written only OD. So this is the problem what is encountered. Though we write, if we write generic, we are happy. Where suppose we write any brand names, and if you give it to the house surgeon or a first year PG, they may write two brand names of the same generic, where the toxicity might be very, very high, and the consultant will be targeted very nicely. So that means to say, with this, the consultants have to look into the discharge summary. At least they have to go through just within a second and see that no duplication has arisen. The dosages are correct. The route of administration is correct. The frequency is correct. That's what you learn from this problem. The main features why we are using this enoxaparin is it's a low molecular weight heparin. It inhibits only factor 10A while producing the conformational changes in antithrombin. See, there are four steps where anticoagulants act. One is antithrombin 3. Next is factor 10A. Next is factor 2J. Okay, these are the areas mainly where they act. Now, when they act on antithrombin 3, all the things are blocked. Factor 10, factor 2A, everything is blocked. So, what happens? There is every step is blocked. So, we also cannot give any antidote. And even if we give the antidote, it has to block at various steps, which is quite impossible. So, the patient is in danger. This is a problem. So, if you use low molecular weight heparin, the first one is the decreased toxicity. That means decreased bleeding. Secondly, the patient can administer himself, that is subcutaneous. Bioavailability is very, very high. How? Because it has got less plasma protein binding. It has directly act. Okay, free drug is more directly act, subcutaneous absorption, the delayed absorption, so less plasma protein binding, all put together, it has got good bioavailability. So long action can be administered only once or twice daily, and all the adverse effects which we meet with unfractionalized heparin like bleeding, osteoporosis, alopecia, everything is lessened. With you unfractionalized heparin, we have to monitor APTT and PTT, whereas nothing is required here. And because it is subcutaneous, no hospitalization, no cost. That is a wonder. And so we use this enoxaparin, but you have to look into the dosage form as well as frequency of administration so that you are decreasing the toxicity and having a good therapeutic effect. So Dalteparin should be administered 100 units per kg subcutaneously BD for 5 days. The main disadvantages are it can't be used in renal dysfunction as it is excreted almost unchanged, and there is partial antagonism to protein sulfate. What is the antagonist to heparin? It is protein sulfate, mainly for unfractionalized heparin. But the problem with protein sulfate itself is an anticoagulant. So when you give protein coagulant, if it has an anticoagulant, already there is anticoagulant, it is added anticoagulant, which is of no use. So the first step for heparin overdose is stop heparin. Because it confines itself to plasma, the metabolism and the excretion is quite fast. So the effect will go off immediately the moment you stop the administration of the drug. But in spite of that, if you give protamine, you have to think and give, because it itself is an anticoagulant. It has got that action. And so what happens? Anticoagulant action further continues. So you have to be very careful. It has got a partial antagonism by protamine sulfate, and low molecular weight heparins are quite expensive. So for that reason, you have to think twice before you administer. Which was the second drug? Second drug was paracetamol. Normally, paracetamol comes in 125, 250, 500, 650, 1000. So where all do you use? 125 most often in elderly or in very young children. 250 up till 15 years of age if they are not very obese, and also mostly above 75, 80 years. The normal between 15 to 65 years, we use either 500. Nowadays, we have got 1000, where we use it in osteoarthritis, where 300 milligrams is the immediate release, 700 milligrams is the late release, and we can administer twice daily. 300 immediate, so immediate effect in osteoarthritis, 700 milligrams for next 12 hours. So the frequency of administration is lessened, the toxicity is lessened, the overdose is lessened, frequency of administration is decreased, and the patient need not have amnesia and take repeated doses. All these are the advantages whenever we have this 1,000 milligram dose administration, but you should know where to prescribe and how to prescribe. So anything above this 1 gram QDS actually it is not 1 gram QDS, it is just 2 grams per day, 2 to 2.5 per day is toxicity. Okay, so this toxicity, how it is overcome, paracetamol toxicity, how it is overcome, where do you see? Normally we see in small children because it is a red color syrup, or in olders because of amnesia. In children, because of the red color, they try to swallow it as and when required, whereas in old people, the pain will not go, pain will be there, little, but how to suffice it? So to just combat, they will try to take these things, and so what happens? That can lead on to, and also amnesia can lead on to toxicity. So how will you combat this toxicity? See, you should understand in 3 steps, which I'll take it in the some other class. But to understand, you just see normally paracetamol is conjugated. It is conjugated by glutathione, and glutathione is one where you don't have the stock in the body. It is just sufficient for 500 milligrams to metabolize. Beyond that, it cannot, because glutathione has to get replenished in the body. So till that time, if at all any paracetamol is there, then there is no use. It goes on for toxicity more than the action. So these are the problems which are met, and so you have to be careful. The normal ones goes on through glutathione, which has got minimal stores in the body, So this is the problem with normal metabolism. But when overdose is taken, what is happening? It gets converted into NABQI, that is N-acetyl benzoisoquinoline derivative. This is the one which causes acute hepatic injury. Okay, for this to get metabolized, glutathione should be there. Where will you get glutathione from? Only 5 for it is suffice only for 500 milligrams. For the rest 2 milligrams or 4 or 8 milligrams, 8 grams, where is the glutathione? There is no glutathione. So in such cases, we are giving N-acetylcysteine both by oral as well as by IV. So when you give by these two forms, you are compacting and you are replenishing. It is a glutathione replenisher. This can be a short term. Glutathione replenisher. It is both N-acetylcysteine as well as methionine. These can be given and the toxicity can be reversed. So these are the ones what you have to remember in this context, where you have to really think within a second before you sit in front of the patient. So thank you for this. We'll go to the next one. All of you can see, I think so. Okay, we'll start with prescribing. We saw the already a prescribed drug. What is the problem with all those things? Now we'll see with prescribing itself, what's the problem? Where are we landing at problem? And how can we really overcome those things? We'll just have a look at it. So I'll just go to the next one. This the same thing is depicted in a different way. See, a person who is the parameters and the details. A person who is 30-year-old man, known epilepsy, on levetiracetam 500 milligrams BD, a newer anti-epileptic drug, and now ongoing seizures started 5 minutes prior, continuous after 25 minutes. It can be just status epilepticus, or it can be refractory epilepsy. So immediately lorazepam 4 milligrams IV was given pre-hospital or wherever the person is, you can give it, which is the drug of choice nowadays. A benzodiazepine, which is given in status epilepticus, and if it is not on arrival, because it was not sufficient, they have given diazepam 5 milligram IV. And again, they were unresponsive. It was a generalized tonic-clonic seizures, tongue biting, and incontinence was there. So he is a non-smoker, minimal alcohol, no recreational drugs, and the weight is 80 kgs. Why weight? Because we have to calculate the dose. Why age and sex? Because age, we have to again see what is the problem, which drug can be administered. And sex, because if it's a female, we cannot administer drugs like phenytoin or sodium valproate, In fact, even carbamazepine also, but to an extent it's okay. But never phenytoin or carbamazepine, because we have got fetal hydantoin syndrome as well as neural tubal defects during reproductive age. So we are not supposed to prescribe those things. So this is the idea what we get by this uh, by this things. And then the examination findings, it was generalized tonic-clonic evidence, tongue biting, urinary continence. So they have diagnosed it as status epilepticus, and seizure lasting more than 5 minutes, and it is unresponsive to benzodiazepine. So please catch these points. We have given lorazepam, diazepam, but it is unresponsive to benzodiazepine, and it is still long lasting. So the first one was, see, you have to write it actually like this in any case, so that just by reading, the other persons will come to know what is given, what is not given, how it was given, whether it came to control, etc., etc. Everything is known. So lorazepam or diazepam is given. Then it's given by IV route. Initial seizure control was there. Later on, again after 5 minutes, it started again. So we can call it, initially it was status epilepticus. Later on, it became refractory epilepsy. So when we have used two terms plus generalized tonic-clonic seizures, we will just go round. We will just have a glimpse and go around the anti-epileptic drugs. So what are the drugs which are used in the treatment of epilepsy? The first line therapy is always, especially in status and refractory, I'm talking first, and later on we'll go to the other ones. As first line therapy, we use lorazepam, diazepam, midazolam, either in status or further continuing in order of choice, we go to refractory. So here, we don't mind about sedation, but definitely we bother about respiratory depression and hypertension. Here, what is the problem? It's only IV, whether it is status or bolus, you have to know about this. Then, when they have told rectal, they should have written suppositories, because we should know the route of administration correctly. Again, IV bolus or IV, sometimes we give these drugs as IV bolus and repeat it. You should know why it is given. Is it for fun? No, there are some reasons. I hope you can find that reason. It's very easy, but it is a forgotten story. Just by the heck of it, because the seniors followed, we will follow. We will not think why it is given repeatedly. Some of them are given by IV bolus, some of them are given by drip, some of them are given only by for few minutes, some of them for hours, some of them for days. So why this difference? What is the problem? Why should we give? The best dose, the best route of administration is oral, as long as the patient can take it. If not, we go for IV, next IM and other things. Okay, so in IV, you have got two types, bolus or stat. It is the same. Drip or infusion, it is the same. So when do we give IV, stat or bolus? When do we give IV, drip or infusion? And even in the drip or infusion, and in the status or bolus, whether we give fast or slow. Okay, and in IV drip or infusion, whether we give it for minutes, hours, days, or even weeks, and sometimes years. So these are the varieties of route of administration which are there, and you have to know the reason for each one of them, not blindly give it to encounter lot of adverse drug reaction. See, we had one reaction for this, I think all of you must have heard this Globac HCM, carboxy maltase, where it has to be given fast because plasma protein binding is there. So for that reason, you should not give it. So you have to give it fast. And they have encountered such a reaction that not just allergy, just not anaphylactic shock. Patient is suffering with stroke. So these are the problems which are met. So you have to keep these prophylactic medications, and you have to start the drip slowly over a period of 10 or 15 minutes. Later on, go on increasing so that no problem is encountered. See, no drug is safe. All are foreign to the body. We can have any amount of interactions in any way we like. There is no hard and fast rule at all. But we have to know to prevent it rather than having it. So these are the different route of administration where we have to have a check so that we can give various drugs in these doses. These you have a revise. If you cannot, then you tell me. I'll give you the example and the meaning and the rationale for it in different routes of administration at different times. Okay, this is the first line therapy in status epilepticus. Later on, we have second line when it is resistant to those or the epilepsy is going on. Then we have phenytoin, phospheniton, valproic acid, and lastly levetiracetam. In order of choice, we use this. If we have started using this, then the patient is in refractory epilepsy. What's the difference between status and refractory? Status is the patient might have had seizures earlier or he might not have had once also. So he starts getting generalized tonic-clonic seizures, say about 2 or 3 minutes, it stops. There's no problem. He goes to PTP, post-ictal depression, and he sleeps off for 30-45 minutes and then gets up. And if at all we have added drug, it depends on the drug. So he may continue for 2-3 hours sleep and he comes back to normal. So that is status, so that he will not have it back. Whereas in refractive epilepsy, after this 3 minutes, it comes back again and it lasts most often for about 25 minutes. And most often there might be even death also. So mainly because of respiratory depression, that's all, central respiratory depression. So for that reason, you have to be careful and you have to be alert with all these drugs. However, how we can really combat. So the best drug will be of the lot Fosphenytoin. Fosphenytoin, why? No cardiac toxicity, very less cardiac toxicity. Where we seen at high doses phenytoin, we have cardiac arrhythmias. So this is a problem. Then we have got cerebral ataxia, dizziness, tinnitus. All these are the problems with phenytoin. So fosphenytoin have got very less of all these things. Normally in resistant cases, we use 20 milligrams per kg IV, max to 150 milligrams. If that is not sufficient, then we go on to valproate. Then more bothered about valproate is pancreatitis. Otherwise, all the others you can manage it very nicely. But pancreatitis is the most havoc in that. Levetiracetam, yes, this is the drug of choice. Left and right, we are using it in all epilepsies and including PTSD, that is post-traumatic stress disorder, and also in very other off-label or uses also we are using, because it has got a very broad spectrum action and also it is little safe, comparatively less adverse effects compared to others. The other drugs of choice, phenobarbital, I don't think we get this phenobarbital also. We may get it only in pediatric wards for neonatal jaundice or congenital hyperbilirubinemia, which I'll be speaking in the next case, where we use it as an enzyme inducer to increase the number of enzymes in the liver, and hence it will conjugate and metabolize the bilirubin, thereby decreasing the jaundice, so that the other fatal things are minimized in that newborn kid. So these are the ones, and so these are the problems which are met. So we use it very rarely. The most common ones for total resistant epilepsy is, or super refractory epilepsy is, propofol or even ketamine. So these are the drugs which you have to remember, because you might be in a remote place, PHC, to a corporate hospital where you can get any of these 9 drugs, and you know to which drugs, to which group do they belong. And most of the drugs act by sodium channel blockers, T channels of calcium channel blockers, increased GABA, decreased NMDA. These are 4 main mechanisms of actions of any anti-epileptic drugs. So these are the ones which you have to remember how they act, so that drug interactions are minimized whenever you're giving one after the other. Now, a glimpse about the mechanism and the examples of drugs in various types of epilepsies in a glance. Okay, normally we use sodium channel blockers, phenytoin, carbamazepine, lamotrigine. I have mixed up both newer anti-epileptic drugs as well as the common ones, that is phenytoin, carbamazepine, sodium valproate, ethosuximide. These are the ones which are the older ones. Okay, all the others are newer ones. Okay, so sodium channel blockers predominantly are phenytoin, carbamazepine, lamotrigine, oxcarbazepine, as well as lacosamide. And most often we use it in generalized tonic-clonic seizures. Okay, and the important features are they are effective mainly in this, but phenytoin has got about 6 features, very common features where you have to really remember it. It has got a narrow therapeutic range, mixed order kinetics, enzyme induction, hydroxylation it undergoes. Okay, and at higher doses, cerebral ataxia, dizziness, vertigo, megaloblastic anemia, and fetal Hydantoin syndrome. See, these are the problems which are met with phenytoin. So never think phenytoin in a female, the only one word. And whenever you have drugs like chronic diseases, communicable diseases like TB, malaria, etc., where we are using these enzyme inducers like carbamazepine or rifampicin, all these enzyme induction drugs, never use, so that both are enzyme inducers or one may interact with the other and cause therapeutic failure. So these are the few very important points what you have to remember. So we preferably use either lamotrigine or carbamazepine depending on the sex and age. Next, coming to calcium channel modulators, mainly there is ethosuximide, where we are not at all using nowadays. Again, we have come back to sodium valproate, which is a broad spectrum anti-epileptic drug. Amongst the newer ones, levetiracetam is the one. Next, mixed and multiple mechanisms, we have valproate, zonisamide, and levetiracetam. All four are there. Sodium channels, calcium channel blockers, GABA enhancers, NMDA receptor antagonists, carbonic anhydrase inhibitors, and also synaptic cycle protein modulators. All actions are seen in many of these cases, more so with levetiracetam, valproate, and lamotrigine. These are the three main ones where we see all these things, and so these are the ones which we are using very commonly. And you have to remember, the valproate, though is broad spectrum, never use it in reproductive age group neural tubal defect. Okay, and zonisamide levetiracetam is very good. Both of them are quite broad spectrum. They have got very minimal drug interactions. Benzodiazepines are mostly used in status and febrile. Or in chronic, it is only add-on therapy. Add-on therapy, never the mainstay in as an anti-epileptic. Phenobarbital almost has lost because of both anterograde and retrograde amnesia, enzyme induction, respiratory depression, because of amnesia, respiratory depression, and poisoning. And the remedy is only forced alkaline diuresis. We do not have antagonists like flumazenil, where we have it for benzodiazepine. We do not have anything for phenobarbital. So the only use of phenobarbital as on today is only in pediatric age group, that too in the neonatal NICU, where there is neonatal jaundice or congenital hyperbilirubinemia. NMDA receptor antagonist felbamate, which is mainly used in Lennox-Gastaut syndrome, and it has got the risk of aplastic anemia, and more than hepatotoxicity, we are more bothered about aplastic anemia. So you have to be very careful about this. Carbonic anhydrase inhibitors, acetazolamide, is used in specific epilepsy syndromes like catamenial epilepsy. But the mainstay of acetazolamide in pharmacology is in glaucoma. Acetazolamide is given either orally or IV in acute congestive glaucoma, whereas topical carbonic anhydrase inhibitors, the congeners of acetazolamide like dorzolamide and brinzolamide, are used in chronic simple glaucoma, where they not only inhibit the carbonic anhydrase and hence decrease the formation of H2CO3, but also it will increase the uveosacral outflow, so that the quantity of aqueous humor is lessened, and so the damage to the posterior structures are decreased, so that there is a delay in the total blindness. And so as long as the person survives, they can really manage the show. So this is the advantage, and more so the advantage with combination therapy like brinzolamide, dorzolamide, and timolol and brimonidine. But timolol, you have to be careful. Even by just topical drops, patient can get bronchospasm. So you have to take the real history and then match along with that. There's the only drug where we have a problem systemically when administered topically. Okay, the latest one, very favorite amongst anti-epileptic drugs, both by neuros as well as non-neuros, is levetiracetam, where we use it for all types of seizures, very minimum effects, and so we are using it in almost all the cases. The drug of choice nowadays is levetiracetam, whether it is pregnancy-induced or refractory epilepsies, or generalized tonic-clonic seizures, or multiple seizures, where because of its minimal side effects. So now, coming back to the question, now I had taken it to a different scenario, different global area. Now we'll come back to the real scenario. So the patient had seizures and it continued even after 25 minutes. So we have to prescribe. This is a case of prescribing, isn't it? Prescribe an appropriate medication to treat the ongoing seizures. And as I told you, weight is necessary to calculate the dose. So first what we had administered? We had administered lorazepam. I hope you remember that slide. Lorazepam or diazepam was administered. Even after 5 minutes, the seizure continued. So I showed you those three slides now. I showed you diazepam, lorazepam, midazolam, then phenytoin, fosphenytoin, okay, carbamazepine, the sodium valproate, levetiracetam. Then we showed phenytoin, phenobarbital, ketamine, as well as propofol. So these are the ones which we are using. Amongst them, we would like to use phenytoin because fosphenytoin is not available. And this is the way you have to write, so that a person who sees next, is it enough or should we go for the next one? So phenytoin is a drug which we have to administer according to body weight. The dose will be 1.6 grams, and the route, obviously it is a emergency. It should be given IV bolus, and the timing will be at 12 noon what they gave it, and the signature should be done so that we will know who was the person who prescribed it earlier and what should be prescribed next. So after 25 minutes also the seizure activity was recurring and there is failure to respond to benzodiazepines. So patient is considered to be status epilepticus, and this should be have been treated with phenytoin sodium, phosphonate, phenobarbital, and in most of the cases phenytoin is the drug of choice to treat status epilepticus, and it is prescribed in the dose of 20 milligrams per kg up to a maximum of 2 grams. Now we will look upon to little bit of this. What's the problem with phenytoin when you give IV or even oral? It is a very good drug for generalized tonic-clonic seizures. But what is the problem with, we will see when we give it orally, because we have to give it for 3 years. Remember, all anti-epileptic drugs once started should be given for 3 years, and there should be no attack for those 3 years. If at all there is an attack, from the onset of the attack, it should be continued again for 3 or 5 years. So what's the problems met? See, you have got in 2 concentrations the phenytoin actions. So in 300 milligrams dose per day means that means it will be 100 or 300 milligrams given at once. When you give 300 milligrams at once, what are the problems? Or if you give 100, what can be the problem? So in subtherapeutic concentration, that is 100 milligrams increment per week or 25 milligrams increment per week over 1 to 4 weeks or more, it reaches the toxic concentration, or 25 milligram per week, it can reach the therapeutic concentration or no toxic concentration up till 600 milligrams. So what happens here? Why this has occurred? Because it is following zero order, it is following mixed order kinetics. So from first order, it has gone to zero order. So this, what happens here? Only the constant amount of drug is constant fraction of the drug is excreted. So it goes on accumulating, and that is the reason why it will cause lot of toxicities both at therapeutic concentration as well as in overdose. So this has to be remembered whenever we are administering phenytoin, whether we have to give 100 milligrams 3 times daily or 300 milligrams once, or should we do therapeutic drug monitoring? And my favorite question, what is clinical therapeutic drug monitoring? You have to maintain the dose, or you have to give a drug holiday, or you decrease the dose on that particular day. So varieties are there. So you have to look after these things and then come to a conclusion whether you can use this or not. Or if you think there is no patient complaints, choose other drugs. You have got umpty number of drugs. You choose other drugs so that you are more safe. As of today, doctors should be safe than the patients. So for that reason, you have to choose the best of the drug, which is quite broad spectrum, that is sodium valproate or levetiracetam. So also lacosamide some of the times. So what's the another problem with with phenytoin? The bioavailability at the level of absorption. Bioavailability is the amount of active drug reaching the systemic circulation when given by non uh, non-parenteral route, non-vascular route. The amount of active drug reaching the systemic circulation when given by when given by non-vascular route, that is oral. So what happens in IV? It is 100, but at the higher level, PG level, it is not 100, because there are some enzymes in the blood which can destroy. For example, succinylcholine. It is destroyed by typical pseudocholinesterase, which is present in the plasma. So these are the problems. So bioavailability, you have to see what is the amount of drug. So in case of phenytoin, what's the problem? See, we have got different manufacturers and different brand names. And this drug has got low or therapeutic index and a narrow safety margin. So whenever we put on phenytoin, we have to think about these, and it should be from a particular manufacturer, that is same brand. Why same brand? We have to decrease the toxicity and we have to maintain the therapeutic effect. So which can occur both at the higher or lower doses. Both therapeutic effect can change or even toxicity can change by the preparations. So whenever they buy the first preparation, you should tell them that they have to get the same preparation for all 3 years as much as possible. Or if they shift on to the different drug, you should be knowing what is the dose of that brand, how much it is, what's the bioavailability, all these should be known, and adjust the dose accordingly. So there is chemical inequivalence. So you are estimating the chemical equivalence. That's why you want the same manufacturer. Okay, because to maintain the chemical equivalence, if you're choosing two different brands, you check for chemical equivalence and then administer it so that the bioavailability is good. So you'll have a good therapeutic effect and lesser side effects. And for careful monitoring to control the epilepsy, TDM, but we cannot afford TDM. So you have to adjust the dose, look after the toxic effects, and the dose should be adjusted accordingly. These are two main important points. One is at that level, what are the problems which are encountered? When you are administered, what is the problem which is encountering? Now, next coming to the important things in anti-epileptic drugs. In the most important things are we are safely using gabapentin, pregabalin, levetiracetam, and vigabatrin because they are they are not metabolized. One, they are excreted and changed in the urine, so you have to look for the renal dysfunction and no enzyme induction activity. No enzyme induction or enzyme induction phenytoin and carbamazepine. Enzyme inhibition is valproate. So these are the problems met. So we have shifted to these drugs. Sedation, headache, dizziness, ataxia are common side effects of the older ones, but also we see the same in the newer ones. So that's why most often we start the dose at night so that seeing that plasma half-life, most of the drug is reduced by morning so that they don't have these effects. And most of them, sometimes they develop tolerance also for these effects. Next, intravenous formulation of carbamazepine is approved by US FDA for temporary use to certain seizures and for oral use when oral use is not visible. But most often we use oxcarbamazepine rather than carbamazepine, especially in PTSD, post-traumatic stress disorders. The next epileptic syndromes presented with multiple different types are Lennox-Gastaut syndrome, Draver syndrome, and juvenile myoclonic epilepsies, where we use commonly the newer anti-epileptic drugs. So both zonisamide and topiramate are sulfur containing, so they may have what? Allergy, sulfur allergy. So one yellow card should be given. Have weak carbonic anhydrase activity. So you have to be careful about H2CO3 and its elimination. Next, it causes weight loss. So you have to be careful. People will be asking his weight has reduced. So you have to know about it. Kidney stones, particularly due to carbonic inhibition. So they can cause oligoamnios, hydramnios when used during pregnancy. So it is contraindicated in pregnancy. Lastly, we will come to know the non-epileptic uses of pregnancy. You can choose either of the panel. Okay, either I have told you in two different things. That's all. Okay, both are same, but to remember, I have thought little bit differently. Let me see so that you can correlate it. We will take the first panel, that is this one. See, the non-epileptic use of phenytoin. Second drug of choice in digitalized induced ventricular arrhythmias because it is a sodium channel blocker. Never use it in atrial because there it is calcium channels, here it is ventricles, it is sodium channels. Next, carbamazepine and phenytoin in neuralgias. In neuralgias, especially in trigeminal neuralgias, we use this carbamazepine and phenytoin. Next, gabapentin, pregabalin. Most often now left and right we are using gabapentin in case of diabetic neuropathy where the patient is almost about to sleep, whether he has got hypoglycemia or hyperglycemia, that's a secondary thing because of gabapentin. And that too, we give 75 milligrams of pregabalin, increased to 250 along with amitriptyline, all sense and nonsense combinations we use. Though pain is relieved to a very small extent, the problem is the dizziness and sleepiness. We have to be careful if they are drivers or if they are going on a long journey, etc., etc. Next, oxazepam and diazepam in anxiety disorders, carbamazepine and sodium valproate in bipolar disorders. Because lithium has got narrow margin of safety, we have to monitor. Though it is selectively acting on the CNS neurons, it has got umpty number of toxicities. So the other drugs used in bipolar disorders in order of choice are sodium valproate, carbamazepine, and lamotrigine. Next, in migraine, we use divalproates of sodium valproate. So these are the things what we usually see according to pharmacology. This is according to medicine what we see. Anxiolytics, these are the ones. Pregabalin, clonazepam, clobazam. Clonazepam, clobazam is also used in febrile convulsions in children. Okay, and also to an extent in something like pre-bipolar disorder in elderly people where they don't get sleep. In such cases, we use it. Migraine relief, prophylaxis of migraine, the favorite drug is propranolol, then flunarizine. Later on, we come to the zonisamide, valproic acid, and topiramate. Mood stabilizer, as I told you, lithium is the first drug of choice. The others are in order of choice: valproic acid, lamotrigine, and carbamazepine. In neuropathic pain, as we have already said, pregabalin, gabapentin, and carbamazepine. Also amitriptyline sometimes. Weight loss is zonisamide as well as topiramate, and anti-Parkinson drug agent as an alternatively we use zonisamide. So you can answer it as non-epileptic uses of anti-epileptic drugs, or you can use off-label uses of anti-epileptic drugs. Both are the questions in PGs. So you can be careful. Don't just depict this figure. You have to explain the action and then you have to name it. Then it carries a lot of value than just knowing that this, that, and be done with it. No, you have to write the rationale for it. And sometimes we don't find it, but most of the time we can understand the mechanism of action. So you have to know that and then write it so that nobody can point out you further. So if at all you write a prescription round the world, nobody should change the prescription. That is your dictum of becoming a doctor. Okay, otherwise you are of no use. If window shopping is done, absolutely you are of no use. So for that reason, always you have that confidence. To have confidence and guts, you should have stuff. To have stuff, you have to read and study and you have to analyze. Only when you do this, you are confident till the last prescription of your life. So that will be the best. Nobody can change in this world. Even the super specialist will bow down to your prescription. So this should be your idea of writing a prescription. Okay, this is about how to prescribe. We saw how it was prescribed, what was the problems. Now we saw how to prescribe. After prescribing, we will see what will be the drug interactions when multiple drugs are given or multiple comorbidities are seen in one single person or in the same person when they come repeatedly at different ages. So one upon the other, they will have problems together. So you have to keep on revising. So for that reason, you have to know these things. Lastly, last but not the least, a case study on drug interactions. Are you seeing the slide properly? Hello? Hello? Okay. So this is the case. I'll just tell you the main ones where we will see in the next slide also. Lower abdominal pain. Okay. Then the patient has GERD, lower abdominal pain. You make differential diagnosis. Then previously had GERD, pulmonary tuberculosis. So they were prescribed isoniazid, rifampicin, pyrazinamide, omeprazole, combined oral contraceptive pill. 24-year-old women, obviously reproductive age, can become pregnant. So these are the main things in this problem. So these are the parameters. Okay, I think in this most of most of the things like abdominal findings are the main. All other things are almost normal. This one, C-reactive protein is C-reactive protein and ESR. Don't be afraid. They are only markers. So you have to find where the problem is. I'll just take 2 more minutes before we go to this problem. Recently, I had a person who was about 24 years old, male, working as a teacher. So he had lower respiratory tract infection, something like you can diagnose something as dengue or chikungunya or viral, whatever it is. So then what happened? He had CRP very high. So they came running, that CRP is so high, we have to get admitted, all those things. So then what happened? I happened to administer a respiratory fluoroquinolone, that is levofloxacin. See, in a group of drugs, you have various specific uses. You have to be thorough with that. For example, because we have taken levofloxacin, I'll just tell you. See, that is a fluoroquinolone. First is nalidixic acid, then norfloxacin, ciprofloxacin, ofloxacin, pfloxacin. Then you have levofloxacin, then sparfloxacin, moxifloxacin, etifloxacin. So these are the ones we have. Each one has its own pharmacokinetic features. The pharmacodynamics is same, the action is the same, but pharmacokinetics differs. So wherever the concentration is higher, you use it in that area. So likewise, levofloxacin concentrates more and more. It is so-called respiratory fluoroquinolone. So we had, I just put them on 500 milligrams of levofloxacin for 2 days. Then it should be given actually once daily, but because it was very severe, I had to put it for twice daily for about 2 days. Then I shifted to once daily. The CRP came down to 20 or even below that by the day 5. So need not be afraid. That's what I told you. You should know everything perfectly. Most of the things are American guidelines. So you have to extrapolate to our Indian scenario by your experience, by the case findings. You can do that and see to it that you can manage the show as much as possible at home, except when the person is drowsy, when the person has got below 90 by 60 BP, below 40 pulse, then hypoglycemia. So these are the ones which really require admission. Otherwise, in almost all chronic condition, you can manage the show in the home itself, because we have got gadgets nowadays. We can monitor this one, oxygen saturation. We can monitor glucose, we can monitor BP, and then we have nebulizers. So we have everything. So still in India, we have people, those who can't afford it. So with this, you can really run the show very nicely, so that even we also develop a confidence next time. And so also the patient, and the cost will be so nice that he will be really be very happy to be with such a person lifelong also, if given a choice, even in next janma also. Okay, so these are the problems. These are the advantages. So don't bother too much when the parameters are very high. You should know how to analyze it. Don't think of numbers. You see the situation and analyze this. You will get to know all the things. This is elevated, especially in inflammation and infection. And urine dipstick, they suggest urinary tract infection, and HCG beta positive. It is the female is pregnant also. So you have to think about so many things. So the diagnosis, it may be appendicitis, pyelonephritis, renal colic, ectopic pregnancy. All these can be your differential diagnosis. Now, coming to pharmacology, I'm focusing more on pharmacology. So we'll come back, rush through this. And the patient is already on isoniazid, pyrazinamide, rifampicin, omeprazole, and OC pills. So they are taking number of drugs. When to take, how to take, what to take, God only knows. Okay, so now I am bothered more about drug interaction here because it's a case of polypharmacy. Okay, case of polypharmacy. The main drugs in TB are the first line drugs, and that too first in first line drugs are isoniazid, rifampicin, later on pyrazinamide and ethambutol. When that is not sufficient, we jump on to other drugs. Omeprazole, the favorite drug of both patient and doctor for any problem from heartburn to long-standing duodenal ulcer, or even Zollinger-Ellison syndrome. And OC pills, even it can be available as oral. The oral contraceptive pills can appear even as OTC if the patient knows little bit, have little bit knowledge of reading, writing, and nowadays Google. They can buy OC pills, or this is the first one. Second one, the patient might be going to a pulmonologist for isoniazid, pyrazinamide, rifampicin, omeprazole for a gastroenterologist, and OC pills for a gynecologist. So these are the problems which are met. So this doctor might not ask that might not ask this. So there are multiple confusions. So this is the whole scenario, what is going on. So you know what are the drugs administered in each of the disease now. Now we will come to the problem here is, the main problem is here isoniazid. The characteristic feature is slow acetylators and fast acetylators, which can cause peripheral neuritis and hepatotoxicity. Neurotoxicity and hepatotoxicity. Pyrazinamide, mainly hyperuricemia and hepatotoxicity. Rifampicin, it is an enzyme induction. Remember, even in the dreadliest of dreams, you should remember rifampicin, because it is used in various conditions, not only in TB, it's also used in case of MRSA strains. It is used in case of rifampicin. Instead of that, we use rifabutin. Okay, and we use it in umpty number of conditions, even in certain cases of leprosy we use. So we use it in many conditions. So you have to be careful about rifampicin. Why rifampicin? Why rifabutin? Why rifampin? So these are the alternatives you have to remember. And more so, an enzyme inducer, very fatal enzyme induction is there. And so you will have a lot of interactions. Omeprazole is an enzyme inhibitor. forget about other things. The main ones are enzyme inhibitor. So you have to know what toxicities can it cause, what therapeutic toxicities can it cause to the other drugs. So should you decrease the dose? How will you manage the toxicity? All this you have to think of. OC pills, they should be in the body for 24 hours. That's why we give only once daily. Okay, combination of estrogen and progesterone. They undergo enterohepatic circulation and they are metabolized in the liver. So you have to combat this OC pills with omeprazole, OC pills, omeprazole with rifampicin. Okay, these two are together with other problems, but they most often they don't interfere. At times they may come, some toxicities might interfere, but more so with these three, that is rifampicin, omeprazole and ocipils. So we'll just flash back through all these things and then come to the problem solving things of this problem. The first one, as I told you, I'm more bothered about enzyme induction or the drug interaction, where the substrate is oral contraceptive pill. The main ingredient, what is included in the liver, is most often CYP3A4, that is cytochrome P450 3A4 enzyme, or CYP2D6 to CYP2C8 to CYP2C9 or to CYP2C19. So the most common reactions occur with 3A4. Common reaction occur with 3A4. Here, these four are the very common CYPs where drug interaction takes place. I have just introduced this. I'll tell you in the next few slides which are the very common important drug interaction what we see in practice or as a or in NEET PG or UG or by teaching or by practicing, all of them. So here, now this is the enzyme inducer. So what do you mean by enzyme inducer? Enzyme induction is a phenomenon where the normal hepatic enzymes will get multiplied geometrically. Geometrically when rifampicin is administered. When will it get increased geometrically? Within 4 to 14 days. Okay, till where? How long it remains? As long as you take out the drug from the body plus 3 more weeks. So this enzyme induction remains for such a long time. So when this enzyme increases from 100 to 1000, this oral contraceptive which should have got metabolized every 24 hours now will get metabolized by the same enzymes, but by increasing the duration. Okay, by increasing the duration, this will get metabolized faster. So what should have stayed for 24 hours will not stay for 24 hours. It will stay only for 18 hours. All of them will get metabolized by 16 to 18 hours. So another 8 hours, no OCPs. No question of contraception. And that's why the lady became pregnant. So HCG beta unit became positive. I hope you have understood. Okay. So this is the problem what we meet. Can it really happen so? When you see all these drugs and what I told you, rifampicin is an enzyme inducer, whereas omeprazole is an enzyme inhibitor. So it will decrease the amount of enzymes. So can it balance? It's a question, $1 million question. We do not know this and we have not encountered clinically many a times. So in that case, to be shrewd, not your prescription should be fall to anywhere. So which can you change? You cannot change rifampicin because it's the first drug of choice. You can change both omeprazole as OC and OC pills also. We'll see it later. Okay, so this is the main one. Now coming to the rest of the things. So in enzyme induction, what all can happen? Therapeutic failure can occur, like rifampicin with OCs. Tolerance can occur. When you give rifampicin for a longer time, you need not see the same actions. The action goes on decreasing because it is getting metabolized faster. So you have to increase the dose. If you increase the dose, it will cause toxicities. So you start giving combination therapy. I hope you have understood the real meaning. Okay. So first, when you use therapy, it can cause therapeutic failure by auto-induction. Okay. It will increase its own enzymes and it will increase metabolism. So therapeutic failure. Next, tolerance will increase because same dose getting metabolized faster cannot act to that extent. So tolerance will limit. So once tolerance occurs, even toxicity can appear. So we can see more number of toxicities, especially for rifampicin, we have flu-like syndrome, hepatic toxicity, urine discoloration, flu-like syndrome. We have many toxicities, so you have to be careful with all of them. Whereas in case of enzyme inhibition, the main drug, as of today, so previously we were very fond of cimetidine, but and also enzyme inhibitor plus anti-androgenic effects. Nowadays we don't use it. As of today, enzyme inhibitor drug is mainly omeprazole. So you have to be careful. Obviously, you can change to other drugs. So you should keep in mind which drugs to really write so that there will be no drug interaction either at the absorption, distribution, metabolism, or excretion levels. So here we have depicted drug interaction at the metabolism level, that is mainly in the liver, because organ of metabolism can be in so many places, but the main organ of metabolism is liver. Now, what are the examples? As I give you this one, no, in the previous slide, see, I have given you a lot of things, all the enzymes. So the few examples to remember in the clinical practice. In the clinical practice, you have see the first one, CYP3A4. This is the most commonest enzyme. Most commonest where all drugs are metabolized. The substrates are cyclosporin, OCP, statins. And the inducers are barbiturates. Which drug? Phenobarbital. Now we don't use it. Thiopental sodium, we use it IV. So we need not bother. Rifampicin, yes, definitely. Because more cases of extrapulmonary tuberculosis. Carbamazepine definitely as an anti-epileptic drug. And St. John's wort. So these can induce these drugs. So the effectiveness of these drugs can decrease. So you have to increase the dose. The effectiveness will decrease. If you increase the dose, toxicity will increase. And enzyme inhibitor for this enzyme, the enzyme inhibitors are erythromycin, a macrolide antibiotic, which we don't use it because not only it is an enzyme inhibitor, it should be given 4 times daily. It causes cholestatic jaundice. It causes diarrhea because of substitute which is secreted in the stomach, and also it causes a QT prolongation. This is the problem what we have with erythromycin. Ketoconazole, again QT prolongation, and grape juice, again an enzyme inhibitor. So these are the drugs which you have to remember. These induction and inhibitor drugs should be remembered. As far as possible, you change it. If not, at least you put an alternative so that we can't change sometimes these substrates. So because of this, you change these in all those conditions so that you will never encounter a therapeutic failure or a drug interaction. For CYP2D6, again rifampicin and quinidine and paroxetine. This is more important than this. Quinidine we are not using nowadays because we have got better antiarrhythmic drugs like verapamil, in order of choice, metoprolol, diltiazem, more than verapamil, diltiazem, then digoxin, lastly ivabradine. In chronic cases, in acute cases, we have adenosine isopranalan, and then we have all shocks and other things, and also in heart block, atropine. Okay, so this you have to remember again. Next, we have CYP2C19, where the substrate itself is omeprazole and it's also an enzyme inhibitor. Clopidogrel, this is a very common drug which we use it as an antiplatelet agent in all CVS conditions where there is aspirin resistance or aspirin toxicity. In both the cases, we prefer to use clopidogrel, but you have to fear of neutropenia. We have to be fearing of neutropenia, which is an adverse effect. Again, rifampicin, barbiturates are the substrates, and fluconazole, which is an antifungal agent, is an inhibitor. CYP2C9, the substrates are phenytoin, which itself is an enzyme inducer. Tolbutamide, which is an anti-diabetic drug, which we no more use it. Warfarin, an anticoagulant drug, which we are not using. We are using specific oral thrombin inhibitors. Rifampin, barbiturate, same like so. It is a inducer for CYP2C, 3A4, 2C19, 2D6 as well as 2C9. So wherever it is occupying every place. So you have to be very careful. Erythromycin and cimetidine are the inhibitors. 1A2 theophylline. We were using, now we are using only doxyphylline. We are no more using theophylline as well as aminophylline. The most common inducers are smoking and rifampicin. And the inhibitors, ciprofloxacin with theophylline is a common theory question in undergraduates. So you have to know. And ciprofloxacin is mainly used in skin and soft tissue infections nowadays, not in others. And is used as a first drug of choice in typhoid fever. In reality, it can still be used. But because of AMR, the fancy of AMR, we are now using the other drugs. Okay, the last one is The last one is CYP2E1. In order of choice, I have put it so that the most common one is this, the least one is this. CYP2E1, acetaminophen, enflurane, halothane are the substrates. Ethanol is the inducer, and disulfiram is the inhibitor, where we will see very, very rarely. Now, coming to few more drugs, specific drugs where we have these interactions: warfarin, drug 1; aspirin, drug 2. Then the interaction is increased free warfarin concentration and increased bleeding risk. The effect of warfarin itself is keeping the blood in an fluid state. If it is more, because of its enzyme induction here, but it has got plasma protein bound interactions also, which I have depicted here. Rationale: they displace warfarin from its protein binding sites, increasing to its free concentration, which will enhance anticoagulant effect and increase the risk of bleeding. So what should you do? Whenever the patient is on these drugs, you have to decrease the dose of warfarin. That is the interpretation. What you have to make, you have to know the rationale, you have to know the interpretation. Only then you are best. Otherwise, like Shah Rukh Khan says in one of the movies, I am the best. So if you want to become the best, you have to know the rationale, and also you have to know how best you can change the drug accordingly. Next, AC inhibitors with potassium sparing diuretics both will cause hyperkalemia. Both will cause hyperkalemia. So you increase potassium levels in the body. Hyper or hypo is always life threatening. So you have to be careful regarding that. Next, digoxin with verapamil. Okay, digoxin with verapamil. Digoxin with verapamil, you see that it is mainly used in anti-arrhythmic drugs, sometimes in heart failure. Absolutely, it is contraindicated, but it should which will have an impact on everything. So you have to be careful because it inhibits renal excretion, increases the dose of digoxin, which has got a narrow therapeutic index. So increase in toxicity, especially cardiac toxicities like atrial arrhythmias or ventricular arrhythmias or even bradyarrhythmias. So both are there because of increased calcium concentration, where you have to explain the rationale. So you have to monitor TDM. Clinical TDM is drug holiday. In reality, blood taking is DDM. And then you have to give drug holiday to decrease the dose of, decrease the quantity of digoxin in the body. And you have to be very careful. You are only looking at the morbidity with digoxin, not the mortality, Okay. Then you have theophylline with rifampicin. We are not using it very this one. So just to finish it, I have told you decreases theophylline levels. Atorvastatin with grapefruit juice. We are very fond of drinking grapefruit juice, and more 90% of people are taking atorvastatin, which will increase atorvastatin levels. The main problem is people start complaining of non-specific muscle pains. Simply they'll be sitting, they'll say muscle pain of the limbs, muscle pain of the back, muscle pain of the this one. So we correlate it to so many things. We start looking for SGOT, SGPT. We look for all C-creatinine kinase, etc., etc., etc. So many things we do just by saying them not to have grapefruit juice, and start with the lowest dose of atorvastatin chronically, say about 10 or maximum 20. They are all high intensity statin. So start at a lower dose on a chronic therapy. So all these toxicities like muscle toxicity, that is muscle pain, including rhabdomyolysis, can be very much decreased. The next, here I have just told you about this. We write left and right this omeprazole and other drugs, isn't it? We just left and right we write it. So these are the medications which will influence the gastroesophageal reflux symptoms. Okay, I have done it in 3 panels. Why? Because drug is not the ultimate in GERD or peptic ulcer. First, you have to look for the weight, lifestyle modification. As of today, weight loss. But actually, you have to come from below upwards to counsel them. So you do these things first. Then you target at the drugs which is causing this problem. Okay, gastric ulcer or GERD. So, for example, aspirin will cause GERD. But what can you do? How can it cause GERD? Prostaglandin inhibition. Mucuses, decreased. Only HCl is increased. That's how it causes. This is the simple explanation. Low dose aspirin on a continuous basis, it causes 5 ml blood loss every day, and this is how it can cause peptic ulcer or even GERD by inhibiting PG synthesis, decreasing mucose, increasing HCl. Okay, they are all prostaglandin antagonists. So how will you prevent it? You should ask the patient to take it immediately with the last morsel of the food. So this much will bring down the GERD. But what we people will do? We will add proton pump inhibitors. With proton pump inhibitors, with these drugs, there can be enzyme inhibition. It can reach to toxic levels. So these are the problems. Or if you are still fond of writing anti-ulcer drugs, or if the patient insists to a maximum level, you have other groups of drugs like histamine receptor antagonists. Or even nowadays you have a newer formulation of antacids like Gaviscon and all those things where you have some raft mechanism where those things will be very sufficient, or the patient will complain of hiccups. So in such cases you are supposed to use baclofen, or if they complain of continuous vomiting, where you can use metoclopramide. So instead of all this, we are very fond of writing omeprazole or esomeprazole. So these are the problems. So you have to look for first lifestyle modification, then the drugs, then the drugs causing, that's what I've written here, medications which influence gastric esophageal reflex symptoms, and then we are using medication therapeutic options, and if at all they are available over the counter, and most of them are available as we are seeing. Proton pump inhibitors, Dest lansoprazole is not available at present, but omeprazole is available, lansoprazole is available, omeprazole is available. These two are not available. Most of them they are given IV. H2 receptor antagonist, though ranitidine has been taken out, still it's a very good drug for nocturnal acid secretion. 300 milligrams given at given at night 10 p.m. Time is very important. 10 p.m. for 6 weeks will abolish all the nocturnal acid secretion. Metoclopramide has got five mechanisms of actions to call it as a prokinetic agent. Baclofen is a skeletal muscle relaxant, centrally acting skeletal muscle relaxant, both at spinal cord as well as supraspinal, 90% spinal, then 10% supraspinal. Lastly, antacids, where some of them are available as over-the-counter drugs. This is a glimpse where how to treat GERD in a normal chronicle way. Not just going on writing omeprazole, tons and tons of omeprazole, very this one very profitable to the company. So these are known as the drugs what we prescribe in any disease for that matter, but more so here because we are doing it day in and day out. They are known as non-prescription medicines. What do you mean by non-prescription? It is over-the-counter drugs. It can be bought without a prescription also. That's all is the meaning. So the main drugs which are available as non-prescriptions are antacids, which neutralize the drug. H2 the antacids, magnesium chloride with aluminum hydroxide, magnesium hydroxide with aluminum hydroxide. H2 blockers reduce the nocturnal acid production. It is a competitive, not non-competitive like PPI, preferably ranitidine. And PPI block acid production and heal the esophagus. The most common drugs which are available as non-prescriptions are lansoprazole, esomeprazole, as well as omeprazole. The prescription strength treatment. So we have to administer it properly. We have to administer for 6 weeks. We have to tell them you have to take it at this time of the day only. All those things should be done. That is known as prescription strength treatment for GERD. So that is mainly esomeprazole, lansoprazole, omeprazole, pantoprazole, rabiprazole, and dex and lansoprazole. We will get 15 mg of lansoprazole also nowadays. So you should be careful in writing what dose you are writing. So, and also strength drugs of H2 blockers are famotidine as well as nizatidine. So now coming to combined oral contraceptives, I'll just go through because time is almost getting over. It is too much. As all of you know, you have got different type of contraception, and in that combined oral contraceptives and progesterone only pills are the ones which are very famous. In combined oral contraceptive pills, the combination is ethinyl estradiol with various progestins. You have got four classes of progestins. The first generation is norethindrone, the most common one which is used. Second generation, both levogestrel and levogestrel is the common one which is used. Third generation, we use gestradone as well as desogestrel, and in unclassified we use mainly drospirenone. And cyproterone acetate we use only in steroid conditions not as contraceptive pills. Why are these generations important? These generations are important. The mechanism of action, I think most of you know this. This is there because of the adverse effects. Okay, all these drugs are known to cause all these minor problems, which will settle over a period of time. But there is increased risk of venous embolism, ischemic stroke, myocardial infarction, with more often with estrogens, and hypertension, cholesterol, rare liver diseases, carcinoma, especially with these progesterone, and also drospirenone is known to be something like spironolactone. So you have got hyperkalemic activity, all these things are mix and match. So all these actions will decrease from norethindrone to drospirenone. That's the reason why we have got various varieties of progestins to be used. And nowadays, most common which is used is um, ethinyl estradiol with drospirenone, where we you call it as Yasmin. Most the common prescription is Yasmin. This is the one which is commonly used by all the young females who prefer this oral contraception. Progesterone only contraception, we don't prefer this because of amenorrhea as well as irregular bleedings. Because of these two problems, we do not prefer progesterone only pills. But nowadays, because of this tech savvy people, people do write, gynec people do write this, but it is not fair writing, and there might be drug interaction, because nowadays we find this extrapulmonary tuberculosis, especially uterine, kidney, and lymph node. These tuberculosis are very common nowadays. So in that cases, we are adding anti-TB drugs, and in reproductive age group, we are adding these oral contraceptive pills or progesterone only pills, because they are tired of getting menstruation. It's a very funny physiology. If we forget, why to lead a life? That is the problem which is faced by these females nowadays, or young people, so to say, gender being no bar. Okay, so this is the one. Now coming to anti-TB drugs, I have told you enough, but you remember the adverse effects: rifampicin, enzyme inducer; isoniazid, peripheral neuropathy, B6 deficiency; pyrazinamide, hyperuricemia; ethambutol, optic neuropathy. But we have to fear about optic neuritis, and so don't prescribe in young children below 6 years, because this optic neuritis, the vision is a subjective symptom. It is not an objective symptom. So for any child which is below 6 years, if you say, no, 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 this is green, they will accept it. Or if it is big, for a small to big, until and unless we have taught them very rigorously, they try to bring down to our answers only. So just don't prescribe ethambutol in case where the child is below 6 years. And these are the second line drugs what we are seeing nowadays. All amino injectable. All aminoglycosides are injectable. Okay. Dream question. All are standard dream questions. And we were using streptomycin. We don't use it because of what? Vestibular toxicity. Because of vestibular toxicity, we are not using this. And injectable. All are injectable, but this is a problem. We are using kanamycin. All are same toxicity: otonephron, neuromuscular blockade, and amikacin. Most often we use this as the drug. These are the three main ones which are used amongst aminoglycosides. Capreomycin, which inhibits protein synthesis. Again, it belongs to the same group as aminoglycosides. Coming to fluoroquinolones, we use levofloxacin, respiratory fluoroquinolone. All have got almost same toxicity except moxifloxacin, getafloxacin, and sparfloxacin, where they have got QT prolongation. So we use amongst them, we never use Gati spar. We use only Moxi, especially in ophthalmic, as topical antibiotics, especially after cataract and also for infections. All of them, irrespective of any ophthalmologist, they are using moxifloxacin very commonly. The latest drugs where we have found it very effective are bedaquiline and delamanate. These are the true anti-tubercular drugs where we are using very commonly. Though it causes QT prolongation, still it has got very better effects, and we use it in resistant cases, or in sometimes as first line drugs itself if the patient can afford, especially under supervision, preferably we try to use this. The other drugs which in line are linezolid as well as protimanate. These are the ones which belongs to the same group as delamanate. These are the drugs which we are using. A glimpse of the drugs used in tuberculosis. Now coming back, we have revised everything. Have you revised everything? Correct? No? Have you revised? Isoniazid, the patient was having what? Left lower abdominal pain. You should think of drug-induced hepatitis and all the other differential diagnoses. That's the first one. Vomiting, okay, and gastroesophageal reflux. So GERD, we have finished. Pulmonary tuberculosis, we have had a glimpse. Okay, a patient is a female, so we thought of pregnancy, and she was on oral contraceptive pill, but still she became pregnant. And the medications. In that medication, what are the problems which are occurring, and what problems can exist, and how can we utilize it in spite of toxicities? All this we have had a glimpse. You have stored in the brain. Now come and answer this question. What diagnosis should be considered for these young women presenting with sudden onset right iliac fossa? Okay, that is the main one. What you should see is efficacy of oral contraceptive agents is reduced by co-administration of drugs that induce hepatic enzyme activity. So the diagnosis can be whatever differential diagnosis I have told you, all of them you should think twice, thrice, and then come to a conclusion, right from appendicitis to pyelonephritis to drug-induced hepatitis to drug interactions can be the greatest problem. Next, potential drug interactions from a medication history, and that should be considered. We will consider this. Sorry, 1 minute. See, now this slide tells you, you concentrate on the red lines. Okay, so we have seen the interaction between rifampicin and oral contraceptive pill. Okay, so the co-administration of these drugs will reduce the effectiveness of oral contraceptive pills because rifampicin is an enzyme inducer, and that drugs inducing hepatic enzyme activity will decrease the activity of the other drug by its enzyme induction. So this case will highlight the importance of drug interaction. So before you prescribe a drug for any patient, ask drug history. Why? Because too many comorbid conditions and too many polypharmacy prescriptions. For that reason, you should and drug interaction. So you have to ask the drug history whenever new medications is commenced. And it is a must that she requires treatment for pulmonary tuberculosis, and we have this enzyme inducing drug, that is rifampicin. So we can't change rifampicin. So ask them to avoid OC pills and choose alternative methods like condom or IUCD, etc. Or next, again, review the patient drug history at every new clinical encounter and consider the potential drug interactions. And now why we are facing the problem? Previously, we used to sit and write the discharge summary. Now it is electronic prescription. Because of that, there is automatically alerted potential drug interaction where they prescribe a medication, thus reducing the risk of the harm to. So you are decreasing the harm to the patient because it is an electronic prescribing as it has increased. So you have to revise and revise. Nothing like human brain. You revise it. Two brand names, same generic name, toxicity. Person will be next day. He would have got discharged today. Tomorrow he will be in casualty. So these are the problems which are met. So be aware. Like how we say be aware of dogs, you should say be aware of drug interactions when you are a perfect doctor. So these are the ones what you should remember as a prescriber. Review potential drug interaction whenever a new medication is commenced and consider methods to reduce the impact of this form of prescription and the toxicities. Thank you very much for your patient hearing for such a long time which is taken. Thank you very much.